on 13th February 2025. And as usual, before we start, just a reminder that this is going to be video and audio recorded, so camera may fall on your laptops, so make sure, please be aware of that one. So as usual, we will be starting this meeting with everyone introducing ourselves. Please go to the mic, switch on the mic, speak, introduce yourself, and then it moves on. Then we start into the main agenda. So let me start. I am Paul Egil-Shelvan, Councillor for Clamlington South East, and I chair Health and Wellbeing Board meeting. Thank you.
Good morning, everyone. Graham Sayers of GP in Alnwick. I am a clinical lead at North East North Cumbria ICB in the Northumberland and North Tyneside local delivery team. Thank you.
Morning, everyone. Jill O'Neill, Executive Director, Public Health, Communities and Inequalities for the Council.
Veronica Jones, Councillor for Ponteland West and Portfolio Holder for Public Health and Tackling Inequalities.
I'm Ali McCudden, Locality Manager for the Norton 19 Service.
Abby Conway, Chief Exec of Citizens Advice, and we're here supporting the voluntary sector from Thriving Together.
Vicky McLeod, Director for Children, Young People and Families.
Neil Bradley, Executive Director for Adults at the Council.
Sharon Williams, representing Community Pharmacy North of Tyne.
Hi, Rachel Mitchison. I'm Director of Delivery for Northumberland and North Tyneside for the Integrated Care Board.
Ross Wiggum, a Director at Northumbria Healthcare.
Wendy Patterson, County Councillor for the Long Houghton Division and also Portfolio Holder for Caring for Adults.
Laura Jobson, here on behalf of Chloe Mann from CNTW.
Morning, Kevin Waring, Police Superintendent for Northumberland.
Yeah, good morning everyone. Kerry Shotton, I'm a Station Manager in the Prevention Department, Northumberland Fire and Rescue Service.
Morning everyone, Sam Anderson, one of the Service Managers for the 0-19 Service.
Morning everyone, Ashley Easton. I'm the Head of Public Health Nursing and Operations here in Northumberland and Gateshead for Harrogate and District Foundation Trust.
Good morning, Rebecca Little from Democratic Services.
Let's look at the first item on the agenda. Apologies for absence.
Yes, Chair, we've had apologies from Graham Binning, Russell Nightingale, Victoria McFarland-Reid and Councillor Jeff Watson.
Thank you very much. Now, I didn't chair the past meeting, so if someone would help me, shall we all agree on the minutes of 9th January 2025? Thank you. Okay. And item 3. Does any of us have any interest to disclose given the items, agenda items? No, nothing. Thank you. So that takes us to the first major item, which is Healthy Families Plan. And it will be presented by Ashley from Harrogate Foundation Trust.
I'm just going to ask Sam to do the technology because multitasking. So thank you everybody this morning for inviting us to present our update on the Healthy Families Plan. This was only ratified on Monday, so we really welcome the opportunity to share our update, and also we've shared our service partner copy of the plan. So what is our plan? Well, our plan is about driving, and it's underpinned by the vision up here in Northumberland, and that's about ensuring every child has the best start in life. We want our children to be happy, healthy and supported by a strong partnership approach, and we have a long-term commitment to those families in Northumberland. The plan describes our service offer up here in Northumberland to our 0-19 population, and it has been developed in partnership with Northumberland Local Authority under a Section 75 partnership agreement. Next slide. So what is our offer? We have a universal and targeted specialist support. This is broken down, into 0 to 5, our public health offer, which includes our National Child Measurement Programme. We have an infant feeding pillar, which is around infant feeding and healthy diets. We have emotional health and resilience pillar. We have our safeguarding pillar, and we also have a really robust mechanism around families being able to communicate with us and engage with us. So we have office duty, which is an allocated health visitor and or school nurse on from 8:30 till 5 p.m. every day, which is run through our single point of contact. We have Health Chat, which is our real-time virtual platform where young people, families or children can engage with us on a platform with a nurse, so they can message in, we receive it at the other end, and we're able to really be responsive and, as I say, communicate in real time. We are a home visiting service, so our 0 to 5 offer is a home visiting service at home with parents. Within the 5 to 19, in the specialist pillar, we have a blended approach where we work with service users and we negotiate where they want to be seen. So in terms of our 0 to 5 universal offer, you can see we have our mandated contacts, which are reflected in the Healthy Child programme. Sitting alongside these contacts, we have some monitoring in there. So examples of those are the family health needs assessment, which we do start at the antenatal period, and it's a really bespoke conversation with parents. It's about really being able to understand the health needs of that family. We have our home environment assessment tool, which again is, you know, a gentle walk around someone's property, being able to have those conversations around safe sleeping, safety, being able to really work with parents to make sure that the environment is safe for that child, and it is, you know, we're really looking at accident prevention. We have our new birth observation training, which sits in the new birth and the 6 to 8, which is the Brazelton training, which is around infant attachment. It gives our health visitors additional skills to work with parents, to really make parents be in tune with their baby's needs and be able to read those responses and cues. We also do a lot of health promotion that runs across all of our contacts, from oral health, weaning, perinatal mental health, parental mental health, substance misuse, tobacco, alcohol. It's really quite broad, and that runs up until the preschool contact. Then we have our 0 to 5 targeted offer, which is any family who require anything above our universal offer, and examples of that can be maternal mental health. If we identify in that universal contact that that mum needs listening or a referral on, that family then go into a targeted section of our offer and receive additional enhanced support. Toilet training, behaviour management are just a few examples, and we do also do relaxed kids for those older children within group work, and we also have a digital response for weaning. So our 0 to 5 specialist offer, this is about us working in partnership with the system to be able to support families with those more complex needs and over that longer period of time. So within the service, we do provide additional ongoing support for vulnerable families. We co-work with other agencies, children with additional needs, those families who are unfortunately experiencing social disadvantage, adult mental health and substance misuse as some examples. We also continue to support and provide support for those children within the safeguarding arena. And again, we adhere to our national and local policies. We also work in partnership with our GPs, going into those conversations within the GP practice around those families that need an additional support, and triangulating the information that we've got within our partnership. Our infant feeding pillar has support across all of our areas in Northumberland, and this includes the provision of specialist support for those mums who are experiencing, you know, some difficulties in breastfeeding. We achieve and maintain full UNICEF accreditation, and we are compliant with our UNICEF BFI standards. We work in partnership with our partners to support partners to have training, to upskill staff, but also to share learning and good practice. and we work collaboratively within the system to ensure that we coordinate care and are a part of a system surrounded by maternity, primary care, family hubs and early years settings. We lead work around breastfeeding in the community, and we have some examples around community capacity where we've supported breastfeeding, and we provide training. If anybody would like any training, please come to us, but we do provide training and have training packages. So 5 to 19 up to 25 for those children with additional SEND needs. We have 6 high impact areas that are built on the early identification of children with need, and we want to build resilience, improve emotional health, we manage risk, keep children safe, and ultimately work to reduce harm. We promote healthy lifestyles with our health promotion offer and our Making Every Contact Count. We want to maximise achievement and learning, and ultimately we want children in Northumberland to have the best start in life and reach their full potential. And we support those with additional needs through our special educational needs and disability reforms. And we support transition for those young people across our 5 to 19. We appreciate that transition can be a challenging time in any child's life, so as a service, we have packages around transition.
So as Ashley's already mentioned there, our 5 to 19 service, we do a lot of our visits within the home environment, but we do offer obviously alternatives such as contact within schools or family hubs, etc. So, we do engage with the children and families to understand where they would feel more comfortable to engage in our service. From a 5 to 19 perspective, we do try our best to complete the home environment assessment tool, which Ashley's already mentioned. So as well as seeing the child, if a child would like to be seen outside of the home, we would of course engage with the family within the home just to do that general home environment assessment also. We do have a universal offer, which we'll talk about in a moment, but within the 5 to 19, we also have that targeted and special offer as well. And obviously we do accept referrals through, we work really closely with the early help team and referrals through the MARF. So within the service, the 5 to 19 side of our service, we have 3 pillars. As Ashley's mentioned, we have the public health pillar, emotional health pillar, and we have a safeguarding pillar. So with regards to the public health pillar, within that pillar we are commissioned to deliver the National Child Measurement Programme, our NCMP programme. We work closely with the local authority to deliver that. And as part of our offer, we go into all schools, building positive relationships within education. And we do heights and weights of all children. We also offer all parents of any children who are underweight support with their weight management. We also offer virtual support if families would prefer virtual support and many group sessions. We will offer low-level mental health support within this pillar. We will do healthy eating, healthy lifestyles, and we get regular referrals into the service for advice and support. We will support with any vaping or smoking advice, sexual health and contraception. We work closely with the sexual health service around which service is appropriate to support. And we have a very successful bladder and bowel pathway. So tier 1 service, that's at really low level bladder and bowel pathway which we have in place. This list is not exhaustive, and we do offer other services. So within the public health pillar, we also have a universal offer where we work with education. From September 25, we'll be offering reception questionnaires into all schools to identify any emerging health needs that families or children require support with. We have a school assembly offer. So each year we will contact all schools who have a year 7 cohort within their education, and we will offer to go into a school assembly and promote the 5 to 19 offer to children directly and share contact details. We also offer a school profile yearly to all education establishments for education to identify their 3 key health priorities, and we will work with education to identify either the most appropriate service to support that school, or ourselves we will go and support and do some either digital or face-to-face offer into the schools. We've also been working with many of our partners this year, looking at public health events, setting up stalls, promoting the service, promoting different health events on the public health calendar, which have been really successful. So moving on to the emotional health and resilience pillar. So this pillar will provide emerging support for any emerging mental health needs to any children. We work really well with CNTW, with SIPS and with primary mental health. We will support low-level anxiety, body image, self-esteem, anger, sleep, bullying. We do some of these sessions in group sessions, so we regularly get education who will contact us, who have a small cohort of students who require that support, and we will go in and support the school in group sessions, or we will go out and offer children that on a one-to-one basis following a family health needs assessment. The emotional health and resilience pillar also offers something called Relax Kids in Charge Up, what Ashley's alluded to. We work in partnership with the family hubs. This again is low-lying support for any child who has emerging health needs, and these are done in group sessions. Any child who we feel are not coping in those group sessions, we will then go forward and support those children in one-to-one sessions. We have the safeguarding pillar. This is the operational side of our service, where we will attend all strategy meetings. And going forward, safeguarding is threaded through the whole of the service, even though we do have a pillar, 5 to 19 pillar for safeguarding. Safeguarding is threaded throughout the whole service, and we work with all children. We also have a specialist safeguarding team. So our specialist nurses, as you can see, do a range of activities. They work in the integrated front door. They will provide training for the service. They will work closely with our children's services partners. They will complete quality assurance around deep dive audits. And there's a list of information such as MAPA, MARIC attendance, MSET, PREVENT, etc. They will also contribute to partnership working with Northumberland Strategic Safeguarding. And they work across the HDFT footprint as well, making sure that policies, etc. are up to date and we're following best practice. Our safeguarding specialist nurses will also participate in any local learning reviews and share them within the service, and also will be part of child safeguarding practice reviews. So in summary, the Healthy Families Plan outlines our universal and targeted offer to children, young people and their families across Northumberland. The service work in collaboration with partner agencies to promote the best possible outcome for children and young people.
Thank you very much. It's a brief presentation covering lots of points. I'm sure there will be lots of questions, so I'll open the floor for questions. Any questions? Yeah, Neil.
Thank you, Chair. Thanks, Paul. Yeah, just a quick one from me. I mean, a huge plethora of services there. I mean, really interesting. What I wouldn't mind seeing, if you've got it as well, is are there any quantitative targets, outcomes, measures of success linked to all of the provision that's in the plan? I mean, I was thinking particularly, you mentioned an emotional resilience pillar in a set of, I mean, a huge issue in society at the minute, you know, around the cultural thing about coping with, and it leads to greater mental health issues or whatever. I'd be really interested in what outcomes and success you get from that as well at the back end of initiatives like that, which see a direct impact in adult social care in terms of the follow-on and potential consequences for us. It was just whether there was quantitative targets linked to any of the things you're trying to achieve, and Separately, I'd be really interested to get that and have a look through it if there was. So.
I mean, we do have key performance indicators that underpin all of our contacts, you know, looking at impact and outcomes for children. We do have a Section 75 meeting with the local authority and share a lot of that information. So in the future we could come and give a presentation on, you know, some of our performance, learning, could be something that we could share.
I mean, it didn't come out with the pack, I don't think, for the meeting. So
No, that's an internal conversation.
So if I understand question, is it that you want some kind of a statistics, how many children went through this program or something like that?
Absolutely, but it's the level of success of the program. I mean,
yeah,
it looks like all the right things, but it's that gauge of success and what we're getting at the back end of it. So.
Chair, if I could just come in on that. Absolutely. So the purpose of today's presentation was we have a Healthy Families plan now, which has been in the making, hasn't it? There is in the forward plan for Health and Wellbeing Board annual reporting for 0 to 19. So I think in future, it's only because this is a new document that it's come by itself. So you're absolutely right, Neil. In future, from an annual cycle perspective, then the Health and Wellbeing Board should be cited on our mandated activity that we have to do within 0 to 19, plus the additional ones that we've agreed as part of our partnership work. So note that it's missing from today, and it will be on the forward plan. Thanks, Neil.
Okay. Yeah. So it's incoming in future. You have some questions here.
I think Neil probably asked my question. The only other thing that I just wanted to ask was in the universal offer, introducing the questionnaire at reception in year 1, and I just wondered what kind of capacity that you had in doing that, and if you are prepared for what you may well get back.
I think as we all know, we do have a small cohort of staff. You know, we're not blessed with a large team, but it's been trialled and tested in other areas across our footprint, HDFT footprint, and it's a range of health questions. And you're right, absolutely right, Vicky. You know, we're looking forward to see what we will get response to. I think as a service we'll be working with partners as well, but I think we will have to look at capacity and demand as a service. What we are hoping is, because of the family health plan that we have in place, we have engaged in quite a robust preschool assessment now, so we're hoping that we will actually be able to pick up a lot of those issues before children go into school. So yeah, we'll certainly be able to bring that information as well.
I think it's really hard because I'm working in another area that's trialled this. The response rate actually was really quite low. So it's really interesting, and I think in Northumberland it's to be tried and tested, and obviously we'll bring it back to this board. But I think we're hopeful that the pre-assessment visit for school will be able to kind of be a little bit of an early intervention with regards to any outstanding issues on going into school.
Yeah, I think one of the things that struck me is you are working very closely with schools and parents, and the plan encompasses all the stakeholders. That's good. The one question I had, maybe I didn't understand, it's a clarification. You, in 0 to 5, you said digital weaning. What does that mean?
So
you quickly went over it. I was hoping you would explain.
Yeah, so what we've got is we know that we go out and we do our contacts to parents, and they receive a huge amount of health promotion advice in one visit. But what we have on the back of that is the digital weaning package, where parents can book on and do the weaning again. You can go on and get that further information around that. I don't know if you want to come in.
Yeah, and we've also we're becoming quite savvy with IT as well. So we've got a YouTube channel where we promote as well, where a lot of the packages that we do deliver are recorded, so parents can access that in their own time on YouTube. So we've got, with regards to weaning, obviously we have what's called a monthly weaning workshop, but on the flip side of that, we have that workshop is recorded on YouTube, which parents can access in their own time.
That's very good, very interesting. Yes, I didn't understand actually, but now I really appreciate that one. Yeah.
It's also information on
pathway for more additional information if a parent or a stakeholder is interested. That's good. Yeah.
So we've also got the 0 to 19 app where information about weaning is on there as well. So we're trying to look at social media as a way of a reach also. So as well as those mandated contacts where we'll talk about different health topics. Some parents have come back and fed back to us that actually they would prefer to have some digital media. You know, life's busy at the moment, so we're trying to listen to service user feedback and adapt the service as well to need.
Yeah, that's a good idea. I would very much look forward to seeing how well it is taken up and then used. Yeah, thank you. Graham, you have anything from?
Thanks for the report. Really useful to see it all again in its entirety. Going back a little while, we had some conversations about integrating with primary care, and I'm just curious to know how you feel that's going and if there's anything else we need to do on that at the minute.
I think what we're looking at in another meeting is our comms strategy and plan, and again how we've engaged a lot of primary care, but it's about now how do we go out there and do that next round, Graham, and really engage people with the ratified plan. So we're going to be revisiting our comms strategy, and I think we've got reasonably positive links across all of Northumberland. Now it's took a little bit of time and we've had to work really hard, but for me I think we probably need to revisit those links because people have moved on and take that plan back out.
There's a lot of discussion around integrated neighbourhood working at the minute, so I think we just need to make sure that you're well included in those discussions as well.
Thank you.
Yeah. Okay, thank you.
Rob, yes, please.
Yeah. Allowing for the sensitivity of the data, is it possible to provide in a simplified format a spatial breakdown of the general support versus the targeted support proportion by different parts of the county?
I would have to go back to our data team and have a conversation about that. I'm not a data specialist. You know, our job is about collating it and it then goes into a data analyst team, but that's something we could explore.
Thank you.
Sorry, one last point as well. Estates. So we have an awful lot of discussion at the minute around using the estates in a sensible way that we all have, but there's obviously a lack of that to a certain degree. Have you got good relationships at the minute around finding places to work and being in the right places?
Yeah, I mean, we've got established hubs and spokes in all across our 3 geographical areas. We continue to, you know, have a really supportive relationship with family hubs. So we have access to family hub buildings for meetings and space where we're not co-located. And we, you know, we are aware that our GP colleagues allow our staff to go in there and have a hot desk, be able to access a hot drink for those health visitors way up in the north. So we do have a lot of good, really positive relationships. We are revising our estates across Blythe to make sure, you know, that we've got adequate provision. But outside of that, we're really established and settled within community bases.
Yeah, a great report and really, really useful to hear it all. And I was just going to reinforce that there's a great connection. You mentioned, obviously, children's services and health services, but actually within the voluntary sector and the community sector, you know, the team have been super users of Frontline and things like that in terms of connecting people up with existing services. And I think to that estates point, I would just sort of suggest that if you were looking for other premises, not to just think about statutory and health services, but to think about actually using some of those community places where people are, the warm spaces and things like that, because that can only help to, I think, entrench you even further in that kind of community work.
I think it might be useful, Abby, if we, because I'm sure with Janelle, who's our community anchor, is very well linked in, but that's about us really, really tapping into, you know, supporting community capacity. So I'm sure with Janelle is tapped in, but I will absolutely make sure that she is.
Thank you. Are there any suggestions, elaborations for our team on the plan? Okay. Shall we accept the recommendations then? Thank you. Thank you very much for your presentation once again. Yeah. Well, we move on to the next item, reports. There are 2 reports. First one is Healthy Weight Alliance annual update. That will be introduced by Councillor Veronica.
So, when we talk about tackling inequalities, I think our main issue is the differential in healthy life expectancy, and that's made up of so many different aspects of our life. So it's not just about eating healthily and exercising regularly, but these two do play a major part. And as a council, I think it's important that we look at the, well, as a council, we're able to look at the evidence, look at the data to know where to target. And I believe we've got a data display outside. So if you've not had a chance yet, please have a look. Provide the information, skills and services that we need for people. So we've got two reports here, and I think it's right that I refer to them both together. The Healthy Weight Alliance Task and Finish Group, that reports back on actions being taken to reduce and prevent obesity. I am simplifying that, David, I realise. And then we've got the DPH report moving in the right direction. This is the annual report of the Director of Public Health. It's not a council report. It's a statutory report that the DPH has to do each year. And I may say have to, I think willingly. It particularly highlights in this one the barriers to exercise. It identifies where we are already succeeding and how we can work together and use our knowledge and skills to support our residents. So I think the two reports go very well together. Thank you.
Health and Wellbeing Board, roughly, I'm not on, am I on?
You're on.
Who did that for us? Someone who's more tech savvy than me. Roughly a year after we first came to launch the Healthy Weight Alliance, and predominantly to update the board on how the first year has gone, but also to seek feedback from the board on what we've done so far and the future direction of the Healthy Weight Alliance. As Councillor Jones mentioned, there's been a lot of work that's gone on. We have identified 3 key priority areas that have been led by 3 task and finish groups within the Alliance, which have all picked up on a whole host of priorities that we are looking to take forward within the next year, certainly, to ensure that residents can achieve and maintain a healthy weight. So just some of the background, I'm sure board members are well aware, and we highlighted last time, the many benefits of being a healthy weight, including health-related quality of life and a reduction in multiple health conditions. We know that actions to support healthy weight have a positive impact on things like employability and productivity of local populations, but can also reduce demands on health and social care, predominantly through increased mobility and independence. The good news is that most children and young people are a healthy weight. Unfortunately, that is not mirrored in the adult population, where only 1/3 of adults are a healthy weight, meaning that 2/3 of adults are either overweight or obese. Even further, there are inequalities associated with healthy weight. No one is immune to becoming overweight or obese. However, there are certain people in the population who are more likely than others, with low income and social deprivation being important factors in the likelihood of becoming overweight or obese. There is a strong relationship between deprivation and childhood obesity. Data from our National Childhood Measurement Programme here within Northumberland highlights the likelihood of children becoming more obese, with, unfortunately, in this graph, will hopefully identify that children who are in our most deprived 20% are almost twice as likely to be overweight or obese than children in our least deprived, with obese prevalence on the vertical axis there, with indices of multiple deprivation on the horizontal axis there. And you can see clearly that each of those bins represents 20% of the population in deprivation quintiles, with our least deprived on the right-hand side and our most deprived on the left-hand side. That simply is not fair. So, on saying that, it's important to take action across the system. That's what the Healthy Weight Alliance looks to do. It looks to adopt the priorities and the provisos that's outlined in a lot of local government association documents that have been trialled and tested with local authorities and wider partners. And the whole systems approach uses things like systems thinking to not only map the causes and consequences of obesity, but also come up with the potential solutions that, as an alliance, we are hoping we will achieve and allow our residents to achieve a healthy weight. Whole systems approach also reflects the local leadership of local authorities. We have excellent representation across the Alliance and excellent attendance across the Alliance. We know that many of the actions to prevent against obesity and overweight don't just sit traditionally within the realms of public health. Things like transport and planning are incredibly important, improving access and opportunities for our residents to be physically active, and ensuring that local developments and proposed developments see the local population have access to good quality food and also opportunities to be able to come together on a community scale and access things like allotments and community kitchen gardens. There's been a lot of work done at a national level. I think it's important to acknowledge this. The key thing for the Alliance across the last year has been how can we reflect some of the national level actions and amplify those on a local level. But I do think it's important to highlight some of the things that national government have put in place to try and ensure that we try and mitigate against obesity and overweight. The introduction of the soft drinks levy was one of the first things that came into place, and that is the reduction or the reformulation of fizzy drinks to try and remove sugar from circulation. That not only has a public health benefit from a healthy weight point of view, but also has dental benefits as well. There's more recently been restriction on volume, price and location promotion. So this is things like buy one, get one free and multi-buy offers where it's often 3 for the price of 2. Calorie labelling for large out-of-home catering for organisations and businesses with more than 250 employees are now expected to put calorie labelling so people can make more informed choices about the foods that they're consuming. And just recently, the most recent one are the advertisement restrictions that have come into play to restrict the advertisement of foods that are high in fat, sugar or salt across TV. There's a 9 p.m. watershed that has come into place which will try and protect mainly children from the harmful effects of advertising. Some of the research that's been done highlights the fact that more than 50% of advertising is geared at foods high in fat, sugar or salt, and during the hours of 3 to 9 where children's viewing time peaks, that percentage goes way above 60%, and that influences the decision making and the nutritional asks from children, who are very, very powerful tools when it comes to pestering parents into buying the latest thing that's on television. So there's really 2 main formats that we are looking to, or 2 main ways that we are looking to try and amplify those national policy measurements. One is through the Healthy Weight Declaration, which has been adopted by both local authorities north of Tyne, or 2 out of 3 in the form of Northumberland and North Tyneside, but also by Northumbria Foundation Healthcare Trust. There are a minimum of 16 commitments that Food Active's Healthy Weight Declaration requires local authorities and trusts to commit to. We've progressed some of the actions within those 16 commitments, but I think it's fair to say that there is a long way to go. We've got quite an extensive active workplace offer. Things like walk to work, bike to work schemes are already in place and are being often promoted to the workforce. There's a relatively good food and drink provision offer from local authority and healthcare trust, where things like product placement of fresh fruit and vegetables is in place, and staff have access to drinking water. And we also have created healthier environments within both organisations. The missing elements and the future focus from a Healthy Weight Declaration will have to look at things like the procurement cycle. I know Northumbria have started doing some of that work from an events point of view, and also from an unhealthy food advertisement point of view. So that brings me nicely onto Northumberland's Healthy Weight Alliance, launched just over a year ago now in 2024, with the vision of increasing the trend in the proportion of people in Northumberland achieving and maintaining a healthy weight within the next decade. I think that last bit is one of the most important things for me. This is not a short-term fix. We've been researching and have known about the impact of being an unhealthy weight now for in excess of 30-40 years. We've tagged on that we are looking at a generational change, with the next decade being a really important element of that. The Healthy Weight Alliance has established a quarterly meeting frequency. It's an appointed and excellent chair in the form of Paul Jones, who is aptly placed with a lot of services under his remit who can influence the local environment. We've created 3 task and finish groups, which I'll highlight in a second, which are going to lead on our 3 priority areas. And as I mentioned before, there's excellent representation and attendance within the quarterly Alliance meetings. Those 3 task and finish groups also form our 3 priority areas for action. Excellent to have colleagues from Harrogate District Trust there, because that goes hand in hand with our children and young people's approach. And you can see that we've subdivided our children and young people into conception to 5-year-olds and then 5 to 19-year-olds, predominantly because of the different needs of those very young children and young people tipping into adolescence, but also from an exposure perspective. Children certainly towards that 5 to 19-year-old are starting to get more independent, starting to make decisions about their dietary intake. So that's why we took the decision just to subdivide those 2 groups. And then the built environment, as I mentioned before, incredibly important in terms of the influence and the opportunity to access healthy food. From a task and finish group point of view, we wanted to ensure that there was a consistency across all of the information and the data that were collected. So there was a sub-task and finish group which produced a pro forma that looked at current work that was being mapped across the priority areas, gaps in provision, and then potential future opportunities. We also asked our 3 community-centred screening questions in each of the task and finish groups, which is what can communities do for themselves, what do they need a little bit of support with, and then what can't they do that local authorities or system partners can do for them. You'll find in the papers there is an Appendix 1, which is about 19-20 pages long, unfortunately, and that has the full summary of all of the detail that we collected from the task and finish groups. What I've tried to do in the matrix that's on the screen there is just do a summary of the summary, if you like, and just highlight some of the work that's going on from a current perspective, from a gaps point of view, and then opportunities moving forward. So current work, there is an awful lot of work that's going on. You've already heard from colleagues in Harrogate District there who are doing an awful lot just by themselves and with system partners, but that is amplified across the whole system, where we've got a whole load of supportive programs from the likes of our health trainers, our family hubs, Harrogate District, within the local authority themselves, and through colleagues in Northumbria Healthcare. We've got policy implementation. An example of that is trying to increase breastfeeding and infant nutrition. There's an award standard which is being rolled out across hospitality, which is trying to implement breastfeeding friendly organisations. We have a whole host of screening tools for our built environment that range all the way through from our healthy planning checklist all the way through to full health impact assessment, which is not only looking to mitigate against the unhealthy harms of unhealthy environments, but also to maximise the health benefits of new developments and potential developments. Some of the gaps, unfortunately, include a clear, consistent messaging around what good nutrition is and what good nutrition looks like. And some of the gaps also include, as I mentioned before, national policy looks to large-scale organisations, things like supermarkets, catering providers on a smaller scale. We are currently very light or not doing anything at all with local catering providers, where we could be working with small medium enterprises, for example, to promote healthy food options and alternatives. Moving forward with regards to the Healthy Weight Alliance, as you'll see in Appendix 1, there are a lot of priorities that have came out of the wash. The Alliance is a relatively small alliance, although well attended. It is still small in terms of its reach. We can't do everything. We acknowledge that there will have to be some sort of prioritisation work that goes on to make sure that we maximise the impact of the Healthy Weight Alliance. We have created an assessment tool which looks at reducing inequalities, which looks at population level impact. We need to be doing things at scale. Supportive programmes are already in place. They are targeted. They are fantastic for those who need them. What we are looking to do is look at priorities that will have a broad reach, and they have to be evidence-based. We must consider the effectiveness of evidence. We'll develop a Healthy Weight Alliance strategic plan, which the board's already acknowledged. It's very important to have success measures and key performance indicators, and we will be including them in future Healthy Weight Alliance strategic plans. We are looking to adopt a data-driven approach to the Healthy Weight Alliance. The NCMP, National Childhood Measurement Programme, has already been referenced this morning. That is one of the data sets that we have got. We have used that to present to the Healthy Weight Alliance, but we are well aware that system partners are also sitting on a raft of both qualitative and quantitative data. We must bring that to the table to ensure that we're making the best informed decisions. Those decisions must also include feedback from the community. It can't just be from a numbers and figures perspective. The hearts and minds of how communities would like to see interventions, if you like, in their local area will be incredibly important. And then also we'll consider how and where the Healthy Weight Alliance can lead and feature in terms of its contribution towards the recently formulated food strategy for Northumberland. Happy to take any questions.
Thank you very much, Mr. Turnbull. Thank you. It was a good presentation. Are there any questions? Yes, please, Kevin. Thank you.
No, thank you very much. Really interesting listening to that. I'm interested to know, is there a disparity, you know, when you put the graph up, 26% in that 20% that you assessed in young people being overweight versus 15% in less deprived? Is there a correlation in that around access to physical education in the system? Because obviously early intervention is key. Do they have access to facilities? Do they have access to sport? Is there a difference in that disparity?
Tough question. I'm not aware. I would have to.
That question, I think, is a good question. We've recently been working on an open space and recreation space audit for the entire county, which looks for quality and quantity, and we will be able to perhaps work with to look at that.
Yeah.
I don't think it will correlate.
Yeah.
It'd be useful to know to an extent there was a pattern.
We do know some of the reasons why. Things like fast food takeaways. We know the prevalence of fast food takeaways is more prevalent in areas of deprivation. So some of the rationale and the reason why children are overweight and obese in more deprived areas is generally to do with the you know, the food environment. But the question that you ask, we'll work with Rob, if you like, and see if we can answer that one.
Thank you. Yes, please.
Thank you very much. I absolutely agree with the whole preventative approach. In health, we are spending an awful lot of time thinking about how to implement the national guidance on weight loss drugs. And I'm really interested to know how our Healthy Weight Alliance see how that will play into people's attitudes towards what a healthy weight is, and whether they see the value in the work that you're doing,
yeah,
or whether there is too much of a other easy outcome for people, and it will change how we have to approach things.
I think it's a really good point. I think weight loss drugs and I think it's important to remember the proviso of the Healthy Weight Alliance, and that is to predominantly prevent people from getting overweight and obese in the first place. But as the data highlights, we are in a pretty poor situation with 2/3 of the adult population currently overweight or obese. It's an interesting question, and I think we need to consider weight loss drugs as a tool in the raft of tools that we've got in a whole systems approach. Whether it'll change the general public's perception of what a healthy weight is, I'm not entirely sure about that. I think we already know with some of the BMI thresholds where weight loss drugs come into play. We're hearing anecdotes that there's perverse incentives to actually put on weight to be able to access drugs, and that's not a culture that we want to create. So I think it's another difficult question to answer.
And I didn't ask it because I had the answer either. And I think it's just, we probably just need to make sure that we don't operate in silos in terms of one hand is doing all of the work on how do we organise the treatment, and one hand is doing all of the work on how do we organise the prevention.
Yeah.
And there is a risk of that because there's a kind of sense of urgency about providing these weight loss drugs.
Yeah.
And there's definitely a pressure to do it as well. Yeah.
Please.
Just to follow on from that, I think as and when the drugs come online fully at a national level, the emphasis is around the promotion of healthy eating habits and physical activity opportunities. And I think the danger is that we prescribe a drug without that wraparound conversation. And then it's back to what do GPs, because that's where the prescriptions are going to mostly be coming from, have awareness of what is available in that community to be able to signpost and refer on to as well.
And one last point, I think the data that you've got about links to deprivation and inequalities, I suspect those people least able to access drugs will also lose out, if you see what I mean. So we might see a widening issue to do with the downsides of obesity because of that.
I think you're absolutely spot on, and because of the stigma as well around weight. We know that one of the issues for those who are overweight and obese not attending healthcare settings in general is because of their appearance and their stigma, that they will be judged for that overweight or obese appearance, and that is something that will have to be the language, the person-centred approach that we'll have to take when we are managing and treating obesity. That needs to change as well.
Yeah. Victoria, please.
So just one question from me in terms of, I can understand where we get the data from around children, but where do we get the data from for adults? You know, I'm wondering if I'm being secretly weighed or something.
It's not, if I'm honest, it's not as robust. We do have an adult data set. It comes through our Healthy Lives survey. It's self-reported. So whereas the National Childhood Measurement Programme height weighs children in reception and year 6, which gives a really robust data set, adults within the Active Life survey are asked the question, and they are asked to self-report against their weight status. So it's nowhere near as accurate as what our data is for children and young people, although it is available.
I could come in on that. We do have incentives in primary care to weigh people from time to time as well. So there is a data set in primary care. So most GP surgeries should be able to work out who is carrying more weight than ideal, although that's dependent on people coming in and being weighed. So it's still, and often those people least able to come, if you see what I mean.
Just a note, I think it's impressive to see that you put a deadline of decade. Within 10 years, you would like to see the outcome coming up. That's good. The deadline is always good, so it helps us to prioritize. There's another point, going on from what Graham said. Yes, we are focusing on prevention, and the drug is going to cure it. But sometimes I feel that when we have this drug, people tend to indulge in more unhealthy eating because the drug will do the business, therefore I'll keep on going in my old ways. So I think even from that aspect, even though there is a bit of a tension maybe there, as Graham pointed out, it's very important, especially when the drug is being let in, allowed in, we must double down on this prevention strategy as well, making people aware of the dangers of unhealthy eating. So in that sense, I see Healthy Weight Alliance having far more significance, gaining far more significance, especially in the light of the drug that is coming in. Yeah, so yes, please.
Yeah, I mean, obviously the report's great, and there's a certain amount of what we can do in Northumberland, which is obviously what the Alliance is trying to achieve. But I'm just minded that, Neil and I were at an NHS event, was it earlier this week? About that whole shift left and about that whole work towards prevention. And there's obviously part of this national consultation. And I've never been part of a less consultative process, really, in terms of the NHS have very clearly defined what they think. And weight loss, Wegovy and stuff like that was one of those things to think about in the future. I agree with everything you've just said, Paul, about it's a pill for an ill, isn't it? And that isn't actually going to fix anything. There's a much wider piece of work around education. But the thing that's missing in that prevention work, and it isn't just about healthy weight, but it's about healthy lives generally, is things like screening for HPV. There's nothing in there about poverty. There's nothing in there about actually the metrics that you're identifying and what compounds that. Because the thing that really was stark for me out of the report and the work that you're doing is there isn't a problem at children, but there is a problem at adults. So what's happening in that intervening period from, we're putting all these protections in around kids, which is dead important, and I completely agree with it. But then it's fallen off a cliff because what are we doing around TikTok? What are we doing around all of that messaging that it's not, kids and young adults don't watch adverts on the telly. My kids don't watch any terrestrial telly. It's all subsumed through those kind of other mediums. So I just wondered if, from a health and wellbeing perspective, there was something to go back to that NHS consultation to kind of be a little bit more challenging. I just wondered if there was an opportunity to kind of, because it did feel, I don't know if you felt on your table, Neil, but my table very much felt like they were pushing down something, and that's a 10-year strategy which is going to make the work that we're doing locally so much harder if we're not actually aligned. Yeah. Does that make sense?
Yeah. Any other suggestions, questions, clarifications? No? Thank you. So I think we are supposed to accept 3 recommendations to continue to support the works of Healthy Weight Alliance and to continue to receive updates and make sure that the priorities align with all the partners. Shall we agree on those recommendations? Thank you very much. Now, thank you very much, David, once again, and let us move on to the item 5B. I think that is the annual report from Public Health Director. But Public Health Director will make an introduction, but it will be presented by Jane and Luke.
Thank you, Chair. And yeah, I'm not going to steal the thunder of Jane and Luke. I just want to say a couple of words around why we've chosen physical activity this year. You'll know that we, over the last 12 months, have been working with the Institute of Health Equity, very much focusing on the building blocks for a good life and the social determinants, housing and employment. But one of the strands around Marmot is also ill health prevention, which is why we've coupled the presentations today with Healthy Weight, making reference to the food strategy and the food partnership. But for me, physical activity is a bit of an unsung hero, and we all know it, we all know about it, but actually it's such an opportunity for us. But the more we hear the message, it can become white noise. And actually, quite timely for us in Northumberland is our new contract with Places Leisure. We've absolutely shifted the dial in relation to that specification, towards inequalities, towards outreach into communities. We've got play zones on the cusp of coming into our area. And really, the report for me is about highlighting developing an incredibly important area that will change healthy life expectancy, it will improve physical health, it will improve mental health. So, and we're at a bit of a point where we're stuck, our statistics aren't changing, we aren't bad, but we're not getting better. So it's a bit of a reset from my perspective, but very much to celebrate what we're already doing here, because there's some tremendous case studies in this report. And this, for me, is about what our community's already doing, as well as what are the larger infrastructures doing, such as our leisure centres. So that's the purpose of the report, to reignite our interest and passion towards the importance of everyone can move more, and the team will talk through that. Massive thank you to the team, Claire Malone sitting over there, who has edited and co-produced this, Luke, David, but a special recognition to Jane Elliott. You won't have seen Jane before, she's a new person coming to present. It's quite often our directors of, the deputy directors of public health or the senior public health managers that come and present to Health and Wellbeing Board. I'm delighted that Jane's here as an advanced practitioner in our public health team. So thank you, Jane, and Luke, over to you.
Just make sure that's on. Yeah, so Jane and I are going to share the presentation today. So Jane's going to introduce us to the report, and then I'll just highlight some of the key features towards the end. So over to you, Jane.
Thank you. So, yeah, as mentioned, this report's looking at our Director of Public Health report for 2024, and the report this year was around physical activity, and the title that we went with was Moving in the Right Direction, Increasing Physical Activity in Northumberland. So, as mentioned, every year the Director of Public Health will produce a report looking at a public health issue or concern that they feel is important to highlight. And this report, it can play a really important role in informing local people about the health of their communities, and also for providing information for commissioners and providers of services on certain health and wellbeing issues. So why do we feel that physical activity is a really important area to highlight? Well, firstly, because we know it plays a really important role in our residents' health and wellbeing. So we know that being active can help residents to have good cognitive and mental health. It can also help to maintain or achieve a healthy weight. It can help to prevent certain diseases, and it can also play an important role in things like strength and balance as well. What we also know is that we will see the biggest health and wellbeing impacts when an individual goes from doing none or very little physical activity to around 60 minutes a week. Therefore, this report looked at supporting those individuals that were doing low levels of physical activity to try and do a little bit more, as this is where we'll see the biggest health benefits and also public health outcomes. We also know that physical activity is really important for our society and also our economy as well. So we know that if people were being more active across the population, this can help to reduce pressure on our health and social care services. It can also help with things like increased levels of productivity within the workplace, and it can lead to things like fewer occupational injuries as well. In regards to active travel, we know that active travel is good for our businesses in retail spend, and that's due to more individuals spending times in shops or accessing things like local businesses. We also know that physical activity can reduce the number of days lost through sickness absences, and it plays a really important role in either managing or preventing long-term condition or conditions. So across Northumberland, there's around 70% of adults that are completing 150 minutes or 2.5 hours of physical activity a week. And this is similar to the England average. That means that around a third of our adult population are not hitting the recommended guidelines set out by the Chief Medical Officer for physical activity. We also know that around 20% of adults are doing 30 minutes or less physical activity a week. And in regards to our children and young people, there's around 50% that are achieving 60 minutes, at least 60 minutes of physical activity per day, which is the recommended guidelines. In regards to active travel, there's around 2% of adults who are cycling 3 or more times a week for travel, and around 10% of adults that are walking for travel 3 or more times a week. Our walking rates, they're significantly lower than the England average, though we do acknowledge that due to the size and geography of Northumberland, it can often be difficult for individuals to achieve active travel. We also know that within our communities there will be certain individuals that are less likely to be as physically active, and that's due to a number of health inequalities. These groups include older age groups, women,
low-income groups, certain ethnic minority groups, people living with a disability, or people with a long-term condition or conditions.
Oops. Go back. Okay.
So just linking into last year's DPH report, which was around ageing well, we know that being physically active is really important for our older age groups as well. So it can help to increase years lived in good health. It can help to keep us independent for longer. It reduces our risk of falls, and it also plays an important role in our mental and social functioning. And as previously mentioned, it plays an important role in reducing pressure on our health and social care and helping us to maintain a healthy lifestyle.
Thanks very much, Jane. So, as Jane's alluded to earlier in the presentation, the Chief Medical Officer recommends that we each do around 150 minutes per week physical activity. But as well as that, really important to build strength, and it's recommended we do strength building exercises at least 2 days a week. And then also improving balance and avoiding the sedentary time. And that's time just sitting still for long periods of time, which is an independent risk factor in itself above physical inactivity. So what Jane said earlier is really important, actually, that this is considered a healthy level, but going from nothing to small amounts, perhaps just achieving 60 minutes, can make a real tangible difference to how people feel and to their health long term. So the report maps out some of the barriers and enablers for physical activity in the population, and we've broken it down into these individual social and physical environmental barriers, which all play a part, and usually people experience a mixture of these barriers together. But this is really important for thinking through what are the things we can do to help people overcome those barriers that they face, but also can we strengthen those enablers that could help support people to do physical activity. So that analysis is really important. And we know that some of these barriers are particularly big for people experiencing inequalities. So an example of this might be, Jane mentioned on the previous slide about women doing low levels of physical activity. This could be to do with perceptions of safety, a reluctance to walk out late in the dark or at night. But there's many other examples we could think of for the other inequalities that we've looked at. So in terms of moving in the right direction for increasing physical activity, we also need to think about the opportunities there are for people to be active in their areas. So the report highlights the work that's being done by Places Leisure, who are in the first year of a 10-year contract from NCC. And what's really baked into this contract is this idea of reaching out to inequality groups and making the service as accessible as possible. But also what we've tried to capture on this diagram is taking physical activity outside of the walls of the leisure centre. So it's a move away from that traditional model of it being about the leisure centre and what happens there, to thinking about improving physical activity and well-being across the whole population. So there's a new active communities programme that's just in motion, just launching, which will really seek to take the leisure offer outside of those four walls and into communities, and really working with community groups to understand what works well for them and how they can be best supported to be active. On the right there, we also emphasise in this report about the asset-based community development approach. And there's a lot of assets or strengths that communities have that they can harness to work together to improve physical activity for communities. So there might be local people with knowledge and ideas, volunteer networks, public open spaces and parks that people could be using, and local facilities and organisations. So it's really keying into the work we're doing with communities first, and encouraging and empowering communities to think about developing and leading those solutions that work for them. Of course, active neighbourhoods is really important. So this is about neighbourhoods being designed to create conditions for physical activity. And obviously the way that neighbourhoods are designed really guides people in the activities that they do. So things like having places to go, whether it's shopping, social or outdoor spaces, encourages people to be out and about and moving around in their neighbourhoods. Good quality, safe and well-signed walking and cycling routes encourage people to be active and to avoid taking the car and take a more sustainable route. And good connections to public transport help people to travel more actively. So it's been estimated that people do around 16 minutes physical activity around a typical bus journey, for example. So really designing these places to facilitate more sustainable and active travel methods is really key. So the kind of thinking about, in comparison, perhaps areas that are designed for the car, and with the car dominance in mind, that might disincentive physical activity. So in terms of working together to increase physical activity, there's work to be done among all of us here today and the partners across Northumberland to think together about how we can work in concert and bring our strengths and gifts to the table to work towards that. So we are planning to develop a physical activity strategy in the next year, and we've been doing some groundwork on that through 8 sector-led improvement workshops, looking at different angles of physical activity, different settings where it happens, and what we can learn about best practice for promoting it in those different areas. But it's also important it links into the wider work we're doing, strategic work such as the Healthy Weight Alliance that we talked about earlier, and also how it links into the 8 Marmot principles that we're embedding in across through the Health and Wellbeing Board and through the different strands of inequalities work with the Institute of Health Equity. So the key recommendations that have come out of the report, so as I've mentioned, refreshing the physical activity strategy is a key piece of work coming up. There's things we're working on as well in terms of healthy design. So in terms of designing neighbourhoods to promote physical activity, there's a new design code that's being developed that we can work with developers at an early stage to help them incorporate active design into neighbourhoods, and then continuing to support development of walking and cycling routes. So there are some that have been put in over the past year, some that are currently in motion, and then more that are planned. And then continuing to work with the leisure and wellbeing contract, and particularly the active communities programme that I described earlier, so taking the physical activity to communities. And then finally, the work with communities themselves to develop new initiatives and thinking about how we can link into Thriving Together and supporting community groups and communities themselves to develop their own programmes that work for them. So that brings us to the end of the presentation. You've got the reports on the end of the rows there, so feel free to take one and have a peruse, and do get back in touch with us about any feedback or questions. Thank you.
Thank you very much for that note. Yes, we will all come back to you. Please feel free to go back to Luke for any suggestion. But at the moment, do we have any questions and suggestions? Yes, please, Ross. Thank you very much.
Thanks for that. That was a really good report and a fantastic presentation as well. I'm just interested in how perhaps we'll work jointly or together to promote some of this and really get it to the people who I think, when I think about our system, 2 million outpatients and network of GPs and all our hospitals, health centres, this is exactly the sort of thing I think would want to, you know, build into the design of that and make sure people are doing it. So I know we do a bit on the prehabilitation and the more serious end where people do need to, you know, move a bit more or do exercise before an operation. But I think just in the general spread of it, it could be a really good one to work on.
That's great. This report did focus primarily on physical activity in the neighbourhoods and in the communities, but there's a lot more that can be done to be thought about in different settings, such as workplaces, hospitals, schools. And I think this physical activity strategy, when we come to develop that, will seek to look at the whole picture in the round and think about what strategic actions we can take across all of those. So, yeah, I think working together to tackle the issue.
Yeah, that seems to be a very good point, actually. I think we are focused basically on leisure centres and asset-based approach. but there are many other ways we can do. I think one of the things I noticed working closely with the Thriving Together, bringing in voluntary and this one, I think this has worked very well in Cramlington in some places. So, you know, we've opened up the Valley Park and it has become and there are volunteers who are maintaining it. And it has become a wonderful place to walk around for, especially the retired people who are many in Cramlington at the moment. So it's really good, that partnership. And there may be other hidden approaches, as you suggested, so it's wonderful. Thank you. Any other comments, questions? Yes, please.
Yeah, just really, really good and fantastic culture as well. We enjoyed looking at that. Just out of interest, you know, we talk about in the workplace, we're seeing more and more people working from home. And is that something that's coming into your strategy?
Yeah, I think that's a key thing. So we'll be looking at all the different settings that people work in and also different sections of the population, different inequality groups, and the particular issues that face particular groups of people. So I think, like you say, office workers, people who work from home, maybe the issue is like sedentary time, so sitting still for long periods of time, but also how can we help people integrate more like physical activity into their days when they do work from home. And I think there's often a lot more focus in the workplace. You know, people are around, you have that opportunity to get up and move around. But at home, you can easily just go through many hours and be rooted to your seat and just think, I'll eat my lunch at my desk. But I think those kind of issues will all be drawn into that conversation.
I think that's a very good point, actually, because one of the downsides of working from home is that it might slowly turn you into a couch potato, sitting on the chair, working on the computer. So, right, so that's a very good point. Thank you. Yeah. Any other? Yes, please. Yes, please.
Just a couple of points, if I may. It would be great if you are sitting here thinking, where else could this be presented to? So without looking at the diaries, Luke and Jane would be very happy to come and present. I'm thinking about the Inequalities Group, for example, Ross, in Northumbria Healthcare. That would be a particularly good audience, just to stimulate thinking it doesn't need a public health person, it's just about taking ownership of it and going away with it into your own organisations. I think the point, Kev, that you've just made, I'm a case study of one. I'll average about 300 steps when I'm working from home and about 5,000 steps when I'm in the office, and that's before I undertake physical activity of my own accord. So it is a key worry, but that's why we need the environments appropriate so people feel like they can step outside their front door and undertake some exercise, and we need our employers to be actively promoting the benefits of physical activity as well, whether it is that led walks or whether it's just encouraging people to take a lunchtime break even. So, yeah.
Yeah, I think 3,000 versus 5,000 seems like a healthy one for me. I think I'll be doing even less. Yes, please.
I think you raised a really valid point about working from home. I'm surprised to hear that the golf, for example, has increased dramatically now that we've got... But personally, I'm more like Jill. I often don't leave my desk till 2, 3 o'clock. I've sat down at 8 o'clock in the morning at home, whereas it's much more easy. I think we've got an opportunity as well to bring, and I think it's really an apt time to have that report on that that movement, because we've got the new Connect to Work, we've got all of the government strategies around employability, and I know we've got the IHE meeting this afternoon about that. But there's a lot of work that we can do with employers about both health, like actual activity at work, but also encouraging people through incentivisation. There's a great deal of stuff that actually employers can offer as part of being great employers, and I think we've got a real good opportunity. So I think it's just about tying that report in with that strategy.
Thank you very much. Any other contributions? Okay, so in that case, I think we are supposed to accept the findings of this report. I hope we do. Thank you. Thank you very much, both of you. And the item number 6 is just noting down the forward plan. Do you have anything to say on that?
Just to remind everyone, March is our closed health and wellbeing session where we'll be focusing on inequalities through work. There is a focus group this afternoon, so health and wellbeing board colleagues plus additional invites will be the focus of conversation about what's the start of the focus groups highlighting and where do we go from here. So it would be good to have that closed developmental conversation.
So that will be in County Hall here. Yes, okay. So our regular meeting will be in April. Then the seventh item is urgent business. I have nothing to say. And as Jill pointed out, the date of next meeting will be 13th of March, 10 a.m. in County Hall, development session. Thank you very much. Thank you for your contributions. Thank you very much. Have a nice day.